Of the medications being prescribed, the top three are analgesics, antihyperlipidemics, and antidepressants. And among those, we're going to look at a couple of examples because these constitute a large number of potential opportunities, both in terms of finding alternatives and adjunctive therapies within functional medicine to reduce or alleviate the need of these medications, as well as opportunities to screen for and address drug-induced nutrient depletion. So let's start by teasing a couple of examples here. All right. First, let's look at analgesics. Let's look at the classic ibuprofen. Ibuprofen obviously is associated with increased risk of ulcers, GI bleed, gastritis, intestinal permeability, edema, and hypertension, especially with prolonged use. One of the major drug-induced nutrient depletions is folate, and folate may not necessarily be directly related to some of these adverse reactions. However, we do know that in our functional toolkit, we have a ton of options when it comes to addressing some of those issues, as well as potentially reducing inflammation so that we could reduce the need for ibuprofen. But what happens when somebody's pain or inflammation exceeds that threshold? Do we want to withhold ibuprofen from them? Of course not. That would be unethical. So we have to start thinking about adjunctive therapy and how do we think about the drug-induced nutrient depletion beyond just that simple single element. Let's look at antihyperlipidemics, atorvastatin. Obviously, the biggest adverse reaction we usually think of is muscle pain and myalgia, as well as increased risk of cardiovascular events and type 2 diabetes. Now, is that directly because of the statins, or is that because we're leaving some factors on the table when we just address dyslipidemia with a statin? Are there other factors that are continuing to push forward the cardiometabolic continuum, and that person ends up with a cardiovascular event and type 2 diabetes? Again, we can think of adjunctive therapies, and we can think of how do we layer some of these foundational pieces so that we could prevent some of these adverse reactions. When I think of myalgia, I think of mitochondrial function. I think of metabolism. And that then makes sense to me that one of the major drug-induced nutrient depletions with statins in general and atorvastatin are CoQ10 deficiencies and carnitine. There are others, but these are the two most strongly established drug-induced nutrient depletions. So you could see how that could play into these myalgias that are occurring in these as a side effect. In terms of antidepressants, let's look at citalopram as an example. Obviously, this is an SSRI. Some of the adverse reactions associated include cardiovascular reactions, including hypotension, tachycardia, and prolonged QT interval, GI disturbances, and changes in appetite. Often we associate SSRIs with increased appetite. Sometimes we see the opposite. We see reduced appetite. That might be because it's coupled with depression and it's not quite controlled yet. Or there could be other factors that play into GI dysfunction that impacts somebody's willingness and ability to eat. That in and of itself can create a nutrient depletion as a result, because if they're not eating the same way, or they're having GI issues and their appetite isn't quite the same, they're less likely to want to make the healthiest choice in every situation. And therefore that could open them up to potential nutrient depletions. Strictly speaking, when you look it up, citalopram only has sodium as a nutrient depletion. You waste sodium as a result, but you can again start to see how there is a composition of challenges here, where somebody that might be on citalopram might have other reasons for having drug-induced nutrient depletions. So my hope is here to start to introduce you to this idea of a holistic approach and a holistic view to drug-induced nutrient depletions, rather than just looking at a single factor and a single outcome so that you could better serve your patients. So let's talk about the DIND cascade and what we often see especially in the conventional model. You've got a patient who presents to their clinician with some new symptoms, and maybe an abnormal lab value shows up. They get started on a new medication. That medication helps to alleviate that original symptom. Their blood pressure improves, their dyslipidemia improves, their headache goes away, whatever it is. However, as they're continuing this medication, they start to develop a drug-induced nutrient depletion that has a particular effect on some part of that patient's body, on a biochemical pathway. Again, think of the stages. It might start at first as a metabolic dysfunction. It might eventually turn into enzymatic shifts. It might eventually turn into outright symptoms, but it's having this insidious background effect. Over the course of weeks or months or even years, that patient now develops a whole new set of symptoms. As we go through those stages, they approach stage 4, stage 3, stage 4, stage 5, we start to see a new set of symptoms that arise and potentially the diagnosis of a new disease state due to that DIND. Does that mean that drug did not do its job? No, that drug is absolutely doing its job. Their blood pressure might still be under control. Their dyslipidemia might still be under control. However, now we have a new set of symptoms. And you can see how easy it is to miss it, especially when the time lapse is so large from the onset of the medication to this development of these new symptoms. From there, you see the patient returns to the physician. Hey, doc, I've got this new set of symptoms. Doc runs some labs, goes, oh, absolutely, you've got XYZ going on. I'm going to give you a new prescription. New medication starts, and we begin the process all over again. Now, am I saying that this means that we shouldn't be addressing the symptoms? Sometimes we absolutely need to prescribe that medication. Like I said, every patient is different. However, what I am saying here is that we want to start thinking about, when we start that prescription, what else can we do to both reduce the need for that prescription changing dose or the beginning of a new medication, and what can we do immediately to do our due diligence to reduce the impact of those drug-induced nutrient depletions. To do that, let's understand some of the various mechanisms of drug-induced nutrient depletions. Let's start first with what we usually commonly think of: inhibition of nutrient absorption. Big one here is PPIs. Part of the reason we think of PPIs like omeprazole and pantoprazole as being such a big area of opportunity for both deprescribing as well as for identifying drug-induced nutrient depletions, because they directly impact the gut and the absorption of nutrients. Like, it couldn't be more clear. They're going to change the pH. They're going to change the production of digestive enzymes. They might alter motility. They're also going to alter dysbiosis, impact dysbiosis, and therefore that's going to have a very direct inhibitory action on nutrient absorption. Next is inhibition of nutrient synthesis. There's a lot of nutrients that we make and or we activate in the body. A great example of this is statins. We make CoQ10. Statins, through their intended mechanism, also alter our ability to make CoQ10. Another example is alterations in the transport of nutrients across the membrane. So this is metformin, which shifts the way that we transport B12 across in the gut. Increase or decrease in metabolism of nutrients. Estrogen, so whether it be birth control or hormone replacement therapy, changes the way we metabolize certain nutrients. It has multiple aspects to this, but just as an example, understand that there are medications that decrease the way that we utilize and then metabolize and activate nutrients. And another mechanism is increasing or decreasing excretion of nutrients. So your ACE inhibitors that might increase, for example, potassium loss and electrolyte balance. Alterations in the body's ability to store nutrients. And this is, for example, caffeine or alcohol. And yes, I consider those drugs because they impact physiological changes. But these, for example, can cause dehydration and electrolyte imbalances. As I said, I just wanted to bring to your attention that the FDA actually associates $136 billion annually with adverse drug reactions, much, much higher than what we saw in that 2013 study. And they actually also estimate that the cost and mortality of adverse reactions in patients are double than in control populations. So this is an area of opportunity for us to really be vigilant and to helpfully, if we could prevent these from happening by addressing basic nutrient status, man, this is not only a huge win economically, but obviously a huge win for our patients as well. All right, so let's talk about nutritional status and specifically the factors that impact nutritional status, because ultimately DIND might be more or less significant depending on some of these factors. So first and foremost, I sort of alluded to this a few seconds ago by saying that in our system, we don't really account for nutritional status as a huge piece when we think about conditions. Maybe in the functional medicine world we do, but conventionally speaking, most of our training has not addressed this. And I think of nutrition status as a spectrum. It begins with having optimal function, and it goes all the way down to outright deficiency. So when I think about where we stand in terms of assessing nutritional status, we often start with deficiency, and then in the middle between deficiency and optimal function is insufficiency. Where we often focus conventionally is outright deficiency. We're looking for places and opportunities that are outright deficient. But know that optimal function is a subjective variable. Different people, because of different circumstances, are going to have a different definition of optimal. It could be genetic, it could be environmental, there could be other factors impacting it. And that's what we're really going to get into today. What does it mean to be optimal? So let me kind of introduce it from this framework. There are 5 stages as defined by this particular article of nutrient deficiency. This is specifically focusing on micronutrients. Stage 1, you have depletion of vitamin stores. So where you have a little bit of a nudge down, and this happens most quickly for water-soluble vitamins. It takes a little bit longer for fat-soluble vitamins. There's not a lot of major consequences when it comes to this, and you may or may not be able to catch these in certain standard measurements of blood or tissue or even urine. Stage 2, you have, as a result of the depletion, some biochemical adaptations. The body, in all its infinite wisdom, rather than going down this pathway, it goes down this pathway a little bit more. And this is where you might see shifts in metabolic processes and therefore the metabolites. And this is often best in urine. Stage 3 is where you have enzymatic changes, because enzymes require cofactors in order to do their job. You start to see shifts in enzymatic function, either an upregulation or a downregulation of certain enzymes in response to shifts in those nutrients. This is where you start to begin to see the first physiological signs of these changes in energy, changes in appetite, changes in sleep or mood, right? Because these are directly impacting some of those biochemical pathways, whether it be essential fatty acids or it be metabolic processes like glycolysis, or it be mitochondrial function, right? This is the first time that you can actually ascribe a physiological change with potential nutrient depletions. This is where I would say that insufficiency begins. Stage 4 is reversible, but it is impairment of metabolic or cellular function. This is where you start seeing outright changes in the way somebody's functioning. An example here might be insulin resistance. So for example, zinc is a very prominent cofactor for insulin optimization. If you have deficiencies in zinc, you might first start seeing shifts in the way the essential fatty acids, the desaturases in particular, shift in and produce some of those our EPA and our DHA and arachidonic acid, for example. However, at some point, the shift in zinc starts to alter our metabolic function, and we start seeing changes in the insulin profile, and we start seeing the development of insulin resistance. So this to me is a stage 4. So that's a difference between stage 3 and stage 4. Stage 5 is potentially irreversible tissue damage or the development of a disease. This is where we see outright signs of micronutrient deficiency. This is often where we catch deficiencies. When we see something that has outright changed or outright become a problem, this is often where we might go back and look for deficiencies or issues. What I would argue is, what if we began at stage 1 or stage 2 to identify these imbalances and started to be more vigilant in the way that we screen for nutritional imbalances. If we made nutritional screening a part of what we do annually or semi-annually as we're screening for disease risk, if we started to utilize metabolic metabolites in the urine, like organic acid testing, so that we can catch these biochemical adaptations sooner, what a huge difference we would make. We would certainly prevent some of the side effects and issues associated with deficiencies, but most importantly, this is how you prevent disease.